I think we're going to get started. Thanks so much for coming out tonight. So today we're going to have the Neurology and Disease panel, part of Brain Awareness Week. I see some familiar faces, so you guys have been coming to events this week. I'll pass out a program at the end, information about what's coming up tomorrow, Friday, and Saturday. So without further ado, I'm going to introduce our first two panelists. We have Dr. Albert, who's a fifth-year child neurology resident here at UChicago. And we have Dr. Marks, who's MD, PhD, and he's a specialist in neonatology and brain injury.
And we also have Dr. Ardelt, who is the director of the Critical Care Research Laboratory, and we also have Dr. Awad, who is the director of the neurovascular surgery.
So we thought that you guys could introduce yourselves, tell us a little bit about what you do, what brought you into the fields that you're in now. Start us off.
Sure. All right. Good evening, everybody. So my name is Dara Albert. I'm in my final year of peds neurology training. That's a total of 5 years. So in my last year. And I did my neurology training here at UOC. I did my pediatrics elsewhere. And I love what I do. I love, neurology is fascinating and treating children is fantastic. It's very rewarding. I see a wide range of neurologic processes in children. So, I don't know what else to say. I'm welcome to, are we taking questions yet? Or do we
just everybody's introduce yourselves and we'll start taking questions.
Okay.
So I had a question for you. So did you go from university to medical school to residency?
Yes.
Which is what most people think you're supposed to do, right? I didn't do that. Maybe I'm here because I had a different path. So my name's Jeremy Marks, and I am a subspecialty pediatrician. I take care of premature babies, and I run a lab looking at brain injury in adults and children over in the next building. I went to university and got a bachelor's degree in linguistics. And then I decided I like languages a lot, and I got a master's degree in linguistics. And my interest was in foreign language and how you make accents, how accents happen. So then I went to UCLA to get a PhD in linguistics. But after about a year there, they said, you've taken enough linguistics, so why don't you go take something really interesting for a while. And so I was teaching English as a second language, because that's something that we all did to make money. And a guy in my class was about my age, and he was here doing neuroscience, and he knew I was interested in how people learn foreign languages and had accents. So he took me to a neurobiology class. And I loved it so much that over the next year, I took some backup courses, and I transferred into the interdepartmental program in neuroscience at UCLA. And I graduated with my PhD about 5 years later. And then I went to medical school. And then after medical school, I went to residency in pediatrics, because I love little kids. And because I had done a lot of work with premature babies as a medical student, because as a PhD student, I had worked with cardiorespiratory data from premature babies who went on to die of sudden infant death syndrome, I wanted to know what babies look like. So I spent time in the neonatal intensive care unit from the time I was a first-year student. So then I went into pediatrics, and I liked neonatology a lot, and I stayed in neonatology. Got a fellowship in neonatology, did an extra year doing research, because I had a PhD, was recruited as a fellow to do neonatology, primarily as research, and then I came here with my first job, and I've been here since 1994, which is not as old as you are, but close. And I spend my day either in the lab or a few months a year taking care of patients.
My name is Agnieska Ardelt, and I am a neurointensivist. So I work here at the University of Chicago in the neuro ICU. I don't have a clinic. All I do is take care of really sick patients that have catastrophic brain or spinal cord injury. And how I got here was pretty circuitous, actually. I started out in art. So I'm a painter and a photographer. And after a little bit of training, I decided I didn't want to do art because I didn't want to sell my pieces, which is kind of a problem if you want to survive as an artist. And so I went and did an undergraduate biochemistry degree only because both of my parents are biochemists. So I didn't really have an idea of what to do after art, but because it seemed natural to default into what my parents did. And then at some point during my undergrad career, somebody said to me, well, you know, your grades are good enough, maybe you should try for an MD PhD program. I said, sure, okay. And so that's how I ended up at WashU, and then I ended up training in neurology. The reason that I decided to do neurology is because I noticed that everyone was almost afraid of neurology. When I was in medical school, people would always, if there was any hint of a neurologic problem in someone, everybody would just stop and say, we have to call neurology. So I kind of felt like I needed to investigate that and sort of figure out why people were so afraid of it. And so I felt it was challenging, and that's sort of what I liked about it. And here I am. What I do is for about 9 to 10 days each month, I attend in the Neuro ICU. And I also attend the Neuro ICU as a combined stroke service. So when I'm on service, I answer all the acute stroke calls. So patients coming in with acute brain ischemia or brain hemorrhage, and we treat those patients. So the rest of the time, I run a lab. So we study in animal models how the brain repairs itself after stroke.
I'm Issam Awad. I'm, as you already heard, a vascular neurosurgeon. So I'm kind of the grandpa in this crowd here. I'm privileged to be here with my young colleagues. I've been in this business for about 30 years. And I got into it also through biochemistry. And it was a time when neurosurgery was, if you want to take a military kind of example, it was like training to be an officer when there were Eisenhowers and Pattons around. It was the age of very few great men and women who basically defined our field. And it was a time where really entering into that field was kind of an awesome thing. And I started in biochemistry until I met one such people who was the chief of neurosurgery at my medical school. And he was one of these Renaissance men that was an accomplished pianist, a mathematician, and a superb surgeon. He was doing an operation that was rarely done, and it's still an extremely difficult operation to this day, where you take 1 millimeter blood vessels and sew them to each other in an effort to improve blood flow to the brain. And I just had to see only one of those operations before I just made the total emotional decision to break away from biochemistry and go into neurosurgery. I never really totally broke away from biochemistry, as it turned out, because in order to do the science side of our field, I had to go back and use my biochemistry, and it was the time that molecular medicine was all breaking out, and I stayed with it, and every few years I would take a sabbatical in which I would retool on the science side to keep the neurosurgery part at the top part. So at the end of the day, my life is like having 3 feet instead of 2, and then in 3 camps. One of those camps, I help lead national trials that enroll patients in some interventions to try to treat hemorrhagic stroke in the brain. So these are novel interventions that have gotten to the point where we're studying them now in phase 3 trials. So we're enrolling hundreds and hundreds of patients all over the world. So this is kind of fun. That pays for about 20% of my time, and it's basically run on an iPad or iPhone, because I get to review images from Israel or Denmark or Arkansas and decide if the patient is eligible and work with the surgeons on the trial. So that's kind of a fun thing, to be able to influence this type of science at a global level. The other foot, and that is paid for by about 40% of my time, is actually a research laboratory that's funded by the NIH, where I study the biology of blood vessels that bleed. So there are genes that cause some of us to have brittle blood vessels in the brain, and understanding how these blood vessels develop, the genes that mediate them, and preventing brain hemorrhage from brittle blood vessels is really what my laboratory does, and has about 7 people that work in the lab. And the third foot, which really otherwise would be full-time for many other people, but I'm lucky to work with a huge team, including Dr. Ardelt and others, that really I basically take care of the patients that need vascular neurosurgery as a result of stroke or to prevent strokes. So that involves carotid surgery, brain aneurysms, and vascular malformations. And that work that I do in the operating room a couple of days a week really defines the technical and clinical aspect of what I do and marries to the research work.
After these really great introductions, all of your work sounds amazing. Do you have any questions from the audience? We'll start just fielding questions. If you have a specific one, just say the name of the person you're addressing it to. But anybody have anything they want to ask? No? Okay, well, I have a question. What are some of your experiences with neurological disease? What do you like? Maybe describe some interesting cases if you're able to, or just what do you think are interesting diseases to work with, and what do you think are future prospects in addressing neurological disease, both from a clinical side and a research side, if you're involved in that?
Do you want to know about what's fun to treat? What's hard to treat?
What would you find interesting that we would find interesting?
That's a big
Why don't
question.
we start at that?
I'll start.
Go for it.
So I think one of the most rewarding things that I do is to treat these patients that are coming in with ischemic stroke. And these patients have blood clots that have lodged in some of the blood vessels in the brain. And the parts of brain are acutely deprived of blood flow. And so if we don't treat that part of brain is going to die, and the patient is going to have may have a big disability. And so we have some means of treating this, and it has to happen very fast. And there is a time window for treatment. The treatment is called intravenous TPA. It's an agent that breaks down clots. And so we have to very quickly figure out if the patient is a candidate for this treatment, and then we have to administer the treatment. And it's very rewarding when the patient really is improved by this treatment. So it's a huge high, and it's something that I really like doing.
Let me compliment that. I think that's kind of boring. Because I think it's basically opening up a clogged pipe, and they're doing it quickly, She does a lot more exciting things than that. So a lot, I think, of the challenge on this field are gonna be in what we can do to extend the time window, what we can do to protect the brain, freeze it in time, to allow a lot of other interventions to take place. What I find more interesting is that almost every case is a little bit different when it comes to blood vessel problems of the brain. Their family background is different, their contribution to the disease, genetic versus lifestyle, is very different. And the impact of the catastrophe, whether it's happened or it's going to happen, is so unique that there is never a textbook answer. And it's always, you get some general guidelines from the textbooks, but we put our heads together a lot about individual cases. And it's really cool to try to kind of create a solution for that patient. That's kind of
Question.
I have one other question. When dealing with
No,
neurological, patient coming in with some sort of neurological disease or complication, midway through treatment, what happens if they lose, their ability to actually understand the treatment that you're providing for them, or how do you communicate, the complications that arise in that way? And even with Dr. Martin here, and you're talking to parents, which is another whole other, thing in general. How do you get that across as a physician?
So sometimes patients coming in with, acute problems that we have to treat quickly cannot communicate, because as you indicated, that could be the syndrome they're having. So they may not be able to understand what we are saying, or they may be able to understand but may not be able to speak. If they are able to understand, communication actually is much easier, because we can find alternative ways of communicating. So for example, I had a patient who couldn't speak but was able to understand, and we had to figure out what time the problem started. And so all we did is we drew a clock with some times on it, and he just pointed to the time. And we did it in several ways, so we were confident that he was saying the right thing and it was correct. If someone can't understand, then we use surrogates, so family members, to essentially, if we're providing a therapy, I always want to discuss the risk and the benefit. If the patient can't understand, then the next of kin is the surrogate decision maker for the patient.
And so that's exactly sort of feeds into what I do, right? Because I can't talk to the babies because they don't speak English. They just sort of lie there. And so I tell the parents, and the parents are, so first of all, I deal with newborns. And although I do deal with some chronically ill kids that are with us for months and the parents are in a different place, most of the emergencies that we deal with are with newly born babies. And the parents have no clue. If the baby's a full-term baby, then they're really, well, if the baby's a preterm baby, they're very upset because the baby came too early and they're not having the delivery they wanted, and the baby's too small and the baby can have all kinds of problems, and we have to deal with that. If the baby's a full-term baby, then they're, if possible, even more upset because the full-term baby that they've made the room for and that they've had ultrasounds on and that they're eagerly awaiting is all of a sudden very sick. And it can be unbelievably sick. And they have to make some decisions very, very quickly. And it's not clear to me how much we can actually inform parents in that state to make decisions about what they should do. Most of the time we say, this is what's wrong, this seems to be the best treatment known at the moment, this is what we'd like to do, and they do this, right? Because they can't do anything else. They can't say, oh, let me go look on the internet to see if somebody in Tennessee has figured out something else. We're lucky in that we're one of the major hospitals in the country. There's a lot of major hospitals in the country. If you drive down the highway, you'll probably see ads for hundreds of major hospitals, even if they're in little towns. But in fact, there are major academic centers across the country, and we all practice essentially the same way because we're all data-driven. But you do have to allow the parents, you do have to recognize that the parents don't have a lot of control, and that makes them very uncomfortable. That's sort of like the emotional part of doing things. I actually wanted to identify, so you don't have a real, in us sitting here, you don't have a cross-section of people who work with neurologic disease. You have a cross-section in age, but we are
Our
all,
age or the patient age?
no, both. From the very young to the very old, and from the younger to the not so young. And I put myself in between.
Yeah.
So
If hair is a measure, that's for
we're not competing at all. But if you listen to what we each said, we're all interested in saving brain from acute injury. You have a little wider expertise because you're learning all about pediatric neurologic disease, but the neurologic disease that I'm interested in is ischemia, which is not enough blood flow to the brain, which babies get when they get into trouble before they come out. And they can be extremely sick and they can be terribly debilitated and develop cerebral palsy and mental retardation and long-term neurodevelopmental disorders. Agnieska works in stroke. She does stroke ICU. And everybody here does some way of saving brain through restoring perfusion, dealing with blood vessels, stopping stroke. But you could just as easily have here someone who works in Parkinson's disease, which is a neurodegenerative disease, or Huntington's disease, or someone who works in multiple sclerosis, or somebody who works in central nervous system infections. I'm missing lots of stuff.
Alzheimer's disease.
Alzheimer's disease, all kinds of, or
Epilepsy.
epilepsy, seizures, right? And so there's a lot of different ways the brain can go wrong. And what you're listing here is people who are interested in the emergency side, people who deal with the acute side, because if you can't get perfusion restored to that brain, then you're going to have major disability, as opposed to trying to stop a brain from degenerating when somebody is 55 or 65 or 70.
Well, I'm not into the degenerating brain part, but my practice, especially since I'm still in residency, is more generalized. So, I'm not only treating emergent cases, but chronic debilitating neurologic illness, or developmental delays, epilepsy, those sorts of things over a long period of time. And I'm always dealing with talking to parents. My patients are never able to fully understand, and even teenagers, they don't want to listen, they don't want to participate necessarily. So it's always a matter of conversation with the family members, with the parents, figuring out what's the best treatment.
Because I work in the neuro ICU, I focus on the stroke side, but I also take care of patients. I take care of any neurological patient that needs to be in the ICU. For example, someone who has myasthenia gravis, which is a problem with sort of the nerve endings and how the nerves talk to the muscles. If they have a crisis, if they have an exacerbation of their disease, they may have to be in the ICU, so I'll take care of them. Someone who has a brain infection, a meningitis or an encephalitis, also, if they need an ICU, I'll take care of them. Someone who has nonstop seizures, continuing seizures, something called status epilepticus, those patients will also come to my ICU. But the point is well taken, is that you're not seeing patients here, except for Dara, who are based in the clinic. Well, you also see patients in the clinic. So we are a little bit more towards the acute end of the spectrum.
We like what makes our heart beat fast.
But there is another, oh, go ahead, ask a question.
Alright, so you guys all deal with like problems in the brain that like pop up. So do you guys ever go back and try to measure the difference in brain activity, or like the difference in a patient before or after, especially because you guys seem to have chronic patients, chronic disorders and stuff. So when they come back from like time to time, is there a measurable difference between brain activity?
Yes, in lots of ways. So function is measurable. There are many scales. There are disciplines in neuroscience that study brain function. There is electrophysiologic activity, if that's what you're alluding by activity.
Yeah, but is it also noticeable, like, if you just saw this person walking down the street? Would it be, is there
Depends
also
on
a
the
difference?
disease
Yeah,
process
it
that
depends
you
on the
talk
disease
about.
process, but interventions and progression of disease has an impact on function, and that's measurable. In the different diseases, obviously, those measures are a little bit different. In Parkinson's, you analyze the gait and the tremor. In neurocognitive disease, you analyze executive, etc. So the consequences are a little bit different. So there are measures for almost every one of the entities that we talk about. I wanted to kind of touch base a little bit, because we touched a little bit on the spectrum of types of brain diseases. But for someone sitting in your seats, you're thinking vertically also. You're thinking about what types of tools, scientific methods are we using to approach these problems. So there is some fundamental, very basic science that is done. There is some science that is attempting to model the disease in various levels of animals, from zebrafish to mammals. There are tools that have to do more with engineering than with medicine, imaging, MRI physics, etc. That bears a lot on what we do every day. And then there are those that study the population science or health studies aspect. So the humanistic aspect, its quantitation, outcomes, psychosocial effect, econometrics of healthcare, huge deal, the cost of various methodologies and so forth. So the neat thing is that you're seeing a very complex matrix, right, that we're talking about, one that involves in the brain alone a huge spectrum of different types of diseases and the large level of approaches you can take. And what each one of you who obviously are already interested in the brain, or you wouldn't be spending a night chatting with us, you have to kind of see where you intersect on that matrix, you know, and then grab a hold of that intersection and see where it takes you, because that's kind of what each of us did in a way.
And to expand on that a little bit, in the future, one of the areas that is really growing is this idea of genetic treatments for diseases, right? As well as kind of on the other side of the spectrum, things that are used in rehabilitation, which is the mind-computer interface, bioprosthetics. So if you're interested in biomedical engineering, that's going to be a huge growth area. Or using gene therapy to treat diseases of the retina as well as other diseases. So those are really important growth areas that are going to be very, very important over the next couple of decades.
I think so. Oh, go ahead.
What are some of the crossovers between all of your work and, say, some of the work of like a psychiatrist? Maybe what are the similarities, some of the differences? When do you work together?
So we have a lot of crossover in child neurology. A lot of common diseases such as ADHD, children with autism, they may see a neurologist and a psychiatrist. Some may present initially to psychiatry or neurology. And then a lot of patients, one of the major things that we also treat is epilepsy, and they may have comorbidities of bipolar or ADHD or other psychiatric concerns. So I'm sorry, does that answer your question? Or
There are certain psychiatric illnesses where delivery of agents to the brain may become a very important part of treating them. We're starting to understand the role of the base of the frontal lobe, the septal area, the amygdala in certain diseases, and the ability to modify that at the local level as opposed to taking a drug that alters your whole body's chemistry. So those are going to be part of the future of neurosurgery, is local, image-guided, function-guided therapeutic delivery. We do that already in diseases like obsessive-compulsive disorder that has failed all modalities. There are clinical trials of brain stimulation, of vagal nerve stimulation to try to alter the mood and result in measurable improvement in function.
So you might say that, so you know that Freud was a neurologist. The father of psychiatry was a neurologist. And of course, you guys have all studied in core, mind versus body, right? And so we really focus on the physical aspects, primarily of the brain, but it is the brain that produces mind. And so the ultimate idea that many psychiatrists don't agree with yet is that we will ultimately understand what brain substrates underlie aspects of personality and mind disorders. But I think we're a long way from that. Yeah, a very long way from that. I mean, it's amazing. It's amazing that we have drugs that can make you feel better when you're depressed. I mean, that's absolutely unbelievable. But that's a very gross kind of tool.
But the last 10 years has altered psychiatry to bring it much closer to neurology and neurosurgery. First of all, this black box has been opened up with functional imaging. So it's no longer a black box where you have to sit at the couch to understand it. Now you can understand brain function, including moods, including various other aspects of thinking and how we reason and how we retain memories with image function. Genetics has altered the disease. In fact, some of the psychiatric diagnoses now are altered by genetic factors and so forth. So I think when all of these converge together, psychiatry will probably be one of these last fields that were analytical and became very scientific.
So one thing that in addition to not having like a geneticist or a Parkinson's person or a myasthenia gravis person sitting here, everyone realize that everyone who's sitting here, we're all physicians. And I think it would be a really good experience for us to be sitting up here with Peggy Mason, who's a scientist that deals with the brain aspects of emotion, or Aaron Fox, who deals with how anesthesia works, or with Gopal, what's Gopal's last name? Thanakan, who deals with the transport of proteins that contribute to the development of Alzheimer's disease. Because you don't have to be a physician in any way to be involved in studying the brain, or in any, you don't even have to be in an allied health profession to be involved in studying the brain or working with the brain. And I think that's something that it's easy to forget. You know, people may say, oh God, I can't live through 4 years of medical school and 3 years of residency, and then I have to get a subspecialty, and then I have to get a job, and I'm going to be 100 years old, and it's just too much, right? You can get a master's degree and do associated research. You can get a PhD and do straight research and have tremendous contributions and be very satisfied. Yeah.
What made you decide to go do an MD after you finish your PhD?
Why did I do that? Well, for me, so when I went into graduate school and I got my PhD, and when I got my lab, and I worked in my lab, my advisor was a very hands-off guy, and he basically said, there's the lab, there's the library, we'll see you in about 5 years. He wasn't quite that hands-off, but it was pretty close. And I spent a lot of time, so I worked with cats, and I worked with sleep, and looked at sleep-dependent breathing, how sleep changes your breathing, and what is involved in those mechanisms. Because we used to think that a lot of the reasons that kids died of sudden infant death was that they didn't arouse properly when they got into respiratory difficulties. But I spent a lot of time in the basement of the university working in the lab. And it was really cool, but I didn't feel for me that what I was doing, it didn't have enough real-world impact for my particular personality. And the woman I eventually married happened to be going to medical school, so I said, I'm going to go to medical school too.
So on the path to becoming a physician, I know you have to do a lot of research. What are some times when you had to use what you were currently researching on in a clinical setting?
All the time.
All the time.
In fact, one of the real cool things about working at an institution like these big academic medical centers, like we have here, is the ability to subspecialize. And that means that you really have the privilege of working with colleagues where you say, this patient came, maybe I'll take care of him in an emergency because I'm on call, but if it's not part of my primary area of expertise, guess what? He or she are part of someone else's primary area of research, and that's who they should follow with. So a big part of my clinic and my OR are tissues and patients that I also investigate. And it's really that riding those different cultures that's really just immense. It's just phenomenal because it gives you the ability to innovate and to create and to apply and so forth. So I think it's really cool.
Could you give some specific examples of one?
Right, so I study a disease that I've studied for about 20 years now, from finding the gene for it till now operating on many patients and so forth. So it's a disease that forms blood vessels in the brain, that you inherit a gene in an autosomal dominant fashion, and then you form these brittle capillaries that bleed. And if those become big, they become lesions you have to take out. They're called cavernous angiomas. So my clinic every week is filled with 2 to 3 patients with cavernous angiomas every single week. The average doctor out there sees maybe one of these every 2-3 years. So the ability to see so many of these patients that I happen to study allows me then to take their tissue when I operate on them and take it to the lab and look at the somatic mutations in the lesion and test hypotheses about that, look at their MRI and look at various things. So we're constantly, and the patients come from all over to the place where the doctor really is interested in their disease rather than someone who tells them, what do you have? I've seen 1 or 2 of these before, you know? So it's that kind of depth that allows you to then apply your clinical work to the lab, but can only happen in big teams where you have the privilege of being able to be selective in what you see and having your colleagues help you, and vice versa. When they see one of those patients, they don't want to look at them. Since you're expert at them, they send them to you.
I think the other issue so it's rare that you have the honor, privilege, and the luck to develop a treatment in your lab that ultimately gets FDA approved, that you can then say, I am working on stroke and I developed a wonderful treatment and now I get to use it. God willing, this all happens to all of us, but we'll all be 100 years old by the time anything gets through the FDA. So it's very rare that what we study informs how we practice. On the other hand, it's tremendously fulfilling, as Dr. Awad said, to work on something and to see the patients that you want to help. So in my case, I'm the guy that sees a lot of the babies that come out asphyxiated, who don't have any blood flow or oxygen delivery around birth. And I don't treat them any differently from my colleagues. There are things that we can do for babies now that may be helpful. We can cool their brains, and so it's easy to cool a baby's brain. You put his or her body down to about 32 degrees, and you keep them cool, and that seems to help babies whose brains have been injured it certainly increases survival, and it may in fact increase their neurodevelopmental outcomes. But being able to see that and to interact with the parents who are dealing with this problem, even though I don't do anything different from my colleagues, really informs how I go back to my lab and work on therapies for brain injury, which is what I do.
So Dr. Marks, can you expand how exactly you cool down? Are you talking about in the lab of cooling down?
No.
In the ICU.
In the ICU.
The temperature of the child.
Right.
So how old is
So there's been about 20 years of research in cooling animals, and now it's pretty standardized. So most of our babies need to be on a warmer to keep them warm because they're sick, and we put a temperature probe usually in their esophagus, sometimes up their butt, but usually in their esophagus, and we put them on a cooling blanket, and we run cold water, and it's thermo-controlled, it's thermistor-controlled, so that it cools the baby until their esophageal temperature gets to 32, and it keeps them there. And that's all we do. I mean, we do a lot of other stuff.
That's not all you do.
We make them breathe, and we watch their blood pressure and do all that stuff, but the ability to cool their body and then thereby cool their brain has been the only major advance in neonatal brain injury forever. The rest of the time, all we do is keep their blood pressure the same, and we make sure they have enough glucose, and we make sure that they're ventilating okay so they can breathe, and we just wait. But now we can cool them, and that helps a little.
And cooling is also used in adult patients who have suffered cardiac arrest. And so those patients are cooled as well.
And bigger kids who might have, brain injury because of near drowning or some other serious injury that leads to swelling in the brain. So.
All these injuries that get cooled are all global injuries to the brain, global ischemic injuries to the brain, where the heart doesn't pump well, and so the brain doesn't get oxygen, or the person doesn't breathe well, and the brain doesn't get oxygen. That's
The coolest thing about cooling is when you have to cool it down so you stop the circulation altogether, so you can do some very complex vascular repair. So at the extreme of applying this technique, we have a method of cooling the body down to the point where the heart goes into into VFib, and then you are on a pump, and then you cool further to the point where you can stop the pump, empty the blood from the body, and keep the temperature between 15 and 17 degrees for up to an hour, with the patient legally brain dead because the EEG is off, the heart is off. But they all come back from this. And it's really, these are the types of extremes that we occasionally have the opportunity to resort to every 1 or 2 years. We do these a lot less often now than we used to. But these are fairly dramatic types of extremes. Our cardiac surgeon colleagues do this about once a week.
What type of case would you use that?
Yeah, so currently it is used for complex brain aneurysm repair where we cannot stop the circulation focally to do the repair. So the vessels are on the other side and you really have to stop the circulation even for a brief time. Even though we have up to an hour, I rarely ever need it for more than 15 or 16 minutes. But with no circulation, it's amazing what you can do, in that time.
Because otherwise the bleeding would be uncontrollable.
Yeah. Otherwise you can't get the patient off the table because of the bleeding.
So I have a two-part question. So how is the emotional aspect to working with patients that might have permanent brain damage? And then the second, is there some potential animal model treatment that is very promising for the future in terms of human patients?
Talk about the emotional side? No? Anyone wants to talk about the emotional side?
I mean, it affects different people differently. Some patients, you have a harder time, you form more of a connection with the families, and it breaks your heart to see their kid, die or have some terrible neurologic outcome. But you learn to, I don't want to say separate yourself, but you learn how to remain objective. And you're there to do your job as a physician and, provide the parents with objective, or patient, whatever, family, with facts. And, leave your own emotions out of it. And then, after you leave the room, sometimes go into the bathroom and have a tear or something. Depends on how it affects you, but.
The other thing is that we're in a, I'm sorry, the other thing is that we're in a different place, right?
Yeah, there is no question that it can take an emotional toll on you to be dealing many times a day with every patient that has the worst illness he or his family have ever had, which is basically what we have in common. So no, this isn't the measles, it's not the flu. So it's a big deal. It's not the gallbladder, you'll get over it. So these are, you tell somebody you have a brain aneurysm, even if there is a 95% chance of getting them through it safely, it's still a highly emotional ordeal, at least by perception and by possible things that could go wrong and so forth. So the way each one of us, I think, have worked out a method of dealing with this. Otherwise, none of us could do this. So the best way I see this is to really look at the disease as the common enemy and then forge a bond with the family to educate them about it and to realize that we can be their partners and pull them through it. And I think that's probably the only way it can work. You cannot become their counselor or you'll just burn down. So you just have to kind of partner with them. I use often the term, we've got a problem. Both of us have a problem. Let's work on it together and that type of stuff.
Some people say to me, how can you work with such sick babies all the time? And I think it's because that I start somewhere else from the parents or the patients. And I'm sure we all feel this way. We are here to help patients. If patients weren't sick, we wouldn't have anything to do, right? So when a patient comes to us, it's an opportunity to help. And so we can make alliances with the family, but we have to start from saying, all right, I'm really sorry, but your baby is sick. This is what we can do to help. And it manages that distance a little better.
I mean, I think it's important to realize that some of the patients would have died had I not been there. And so I can't save everyone. And I'm not expecting to save everyone, but I'd like to try. And some of the patients that have less brain injury than they would have otherwise had, those patients keep me going in a way. So when I have a tough case, I can always think back to the patients that I did save, knowing that no matter how I try, there's some patients I can't save.
And the good news is that with today's technologies and interventions and teams, illnesses that, at the beginning of my career were very frequently lethal or disabling despite everything you do. Right now, we are hard on ourselves when there is a complication in those cases, which is an amazing, the bar has been raised in what medicine can can offer. And it's really immense to have somebody that is surely gonna die if you don't do anything, and you've basically fixed it for them. I mean, this is really pretty cool stuff, and makes it worth all the misery you have to go through to be able to do that.
So one of these diseases is something called subarachnoid hemorrhage. So a couple of decades ago, people were worried about people dying from this disease. How do we prevent people from dying? At this time, we're more worried about their cognitive outcomes. So it's a different goal now, because so much has been learned about how to prevent these patients from dying. Now we have a different goal. How do we make their minds better after they survive this? So it's quite amazing, actually, over a few short decades.
Glass
This
moving
happened.
from 50% full to now being hard on ourselves that it's 90% full. It's good.
Right, and we're worried now that, oh, that patient had some memory loss at the end of all this, you know? Whereas before it was that patient died.
With that goal transition, this one, I'm sorry, will be more for Dr. Marks, just in terms of seeing your patient population, with developmental, disorders that you can catch from a neurological point of view early in development, do you see your patient's survival as your goal, or the parents as your patients, and whether or not the child will be healthy?
Oh, I tell families that I take care of everybody. And so what we try to do, I think, is we try to have the best outcome for the baby as possible. We let the parents know what we know and what we don't know. And that's really important, because here's what we know about kids. There's a wide variety, and there's some diseases. Your baby could be fabulous, your baby might be mildly impaired, your baby might be severely impaired, and at this stage we just don't know. But we will follow with you, and we will never abandon you, because that's what families are more scared of than anything else. Even if the parents have to make a decision to take a baby off support and let them die, we say we will be there with you the whole time and afterwards. And that's really the physician part. Right? They're not just pieces of tissue that we can make better or worse.
Any question?
On a brighter note, what are some more fun, exciting developments that are happening right now that are getting your hearts pumping in neurology? Some new techniques that you're excited to try out? Anything more?
Do you want to talk about the studies?
Yeah, I mean, the fact that we have new ways of treating some diseases that were only kind of dreamt of a generation ago, and now they're being tested with a real hope of improving outcomes. So one of those diseases is when something goes really horrible, which is intracerebral hemorrhage. So you leak blood in the brain and it forms a big clot. It's kind of a destructive mass. And the worst of it is not that happened. The worst of it is what happens the next week as that mass starts causing inflammation and mechanical shifts in the brain and further tissue damage. And patients often dwindle and end up in a nursing home. We've all kind of seen grandparents and other people do that. So we have an opportunity now to do a procedure that puts a catheter in the brain and actually do the counterintuitive thing, which is give clot buster into the hemorrhage to try to kind of get that blood out of there, wash it out of there within the first 1 or 2 days prior to this edema phase and toxicity phase. And you'd think that that's kind of science fiction, and in fact, when we started doing it in the early 1990s, people were told, you're crazy, what are you doing? These people are gonna die anyway, what are you doing to them? Now they are in phase 3 trials. We are one of those sites. Dr. Ardelt runs our site. I help oversee the national trial, where we're actually treating 250 patients with this, 250 patients without it, and it's gonna change practice. So to be part of that, so that the next future generation of neurosurgeons will do this as a matter of practice standard, and you helped bring it to that point. It's amazing, so that's kind of what the privilege again of doing some of those things that we do.
I think one of the most exciting things in pediatric neurology is actually what he does in the NICU. Whereas, many years ago, babies who were born premature, they might have horrible outcomes, and you see, let there be light. You would see like devastating neurologic outcomes. Now we are understanding more and more the physiology of little teeny babies, and we can, try and decrease the hemorrhages that occur, or try and protect their brain with cooling, where these babies may actually have normal developmental outcome. I see them many years after he's done with them, and they may be normal kids, and you wouldn't know that they were born at 24 weeks gestation. So I think that's really exciting.
What do you do when you come across a case you've never seen?
You haven't seen before?
Yeah.
Open a book.
Yeah,
Go back
so
to
nowadays
the
it's a
text.
lot easier, right? So you don't even have to open a book, you go on the internet.
Wikipedia.
Yeah, no,
Up to date.
yeah. The fact of the matter is that if you subspecialize, there is a lot fewer of those cases. So you have to work in an environment where the rare case is a known entity to somebody. And then you change a case from being mysterious, mismanaged, bad outcome, to one where somebody is saying, I either know this, or I'm working on it, or whatever. So the idea here is to work in these types. So we treat a number of rare diseases that the average doctor has never come across. And if they keep those patients, it's not gonna work out very well, So if they end up with somebody that's a real specialist in this, they're easy for them. So, some of the patients that are born with muscle diseases may look like a hugely misunderstood, whatever. You send it to your clinic, you have it classified, this is type 2A, this is what we do for it, or you better check your sisters, but not the brothers, you don't have to worry about that because it's X-linked, and somebody has it figured out, what to me looks like a riddle. So I think medicine in this big, complicated age of knowledge should really no longer be riddles. Every riddle should have somebody studying.
I think it helps, speaking as a resident, because a lot of things are new to me, it helps to have a system of approaching patients, and I may not recognize exactly what the disease is that I'm looking at, but there might be pieces of it that, point me in one direction or another, like I can pinpoint whether it's a muscle disease, or is this a brain disease, or a spinal cord disease, and then that kind of helps guide my, go and look through the book or look online or whatever and try and figure it out.
I would just make 2 points. The first thing is that for most things, there's nothing new under the sun. And there will be somebody somewhere who has seen something, or seen more of them. And with our massively interlinked network now, it's becoming much and much easier to find out who knows the most, whether it's somebody in Pittsburgh or somebody in Texas or somebody in Italy. And so that's very, very helpful.
Or somebody down the hall.
Or with luck.
Yeah. Often, actually, it's somebody down the hall, I find, that you just didn't know are actually the world authority on this, and you didn't really know it.
And the other thing I just
Because
want
you
to say,
didn't
because you're
recognize
gonna cut us off, is that medicine's knowledge expands all the time. And there's no way that any of us walking around has it all under our heads. If I learn one more thing, I'm going to forget how to put my pants on because it's just going to push everything out. So the approach to take is to know how to find information, not to memorize it all. And if you can take that, that's what lifelong learning is all about. And so I think that's an important expectation for yourself when you do anything, is that you just can't learn it all. You can't even learn part of it.
So we started 5 minutes late, so we're going to end 5 minutes late, and I just wanted to ask our panelists to do a couple of last closing remarks for the audience, just a couple of things that you'd want us to get from this talk.
Okay, so child neurology or pediatric neurology is a very wide range of patients, a wide range of diseases. We see the itty bitty little guys in the NICU all the way up to 18, and some centers see up to 21 years of age. So my day can be the gamut. I may start off by seeing a little baby, and then in the afternoon I'm seeing a teenager. I see all types of neurologic disease, which makes it really interesting. And the really fun part is how the development, so a child is an ever-changing organism. So you're always thinking about their development and where are they in their development, and how do the diseases that they have change that developmental trajectory, how do the medications that I give them impact that developmental trajectory. So that just adds a really interesting piece of it to what I do, which I find particularly fascinating. So child neurology is awesome.
I don't have much. The brain is an amazing thing, and we are learning so much, and there are so many ways to ask questions about it, to take care of people with problems with it, that it's never going to be a source of relief.
I don't know much to say either. I think that pretty much anything you choose, as long as you keep learning and finding new things, it's going to be fine. And I think the next decades are going to be really interesting in terms of development of, like what I said, bioprosthetics and things like that, where there wouldn't have been that possibility a while ago. So just keep learning.
I think I'll conclude by going to a very fundamental philosophical principle. What did the Oracle of Delphi say that was the most important thing that she taught Socrates? What he wants to say? Know thyself, right? Know thyself. So that is the first, foremost principle of philosophy. And if you really know what turns you on, what really excites you, brain science offers huge opportunities at the interface of many different things. You just kind of decide, are you the thinker here, are you the philosopher, are you the historian, are you the sociologist, and there'll be something in brain science for you, and just grab onto it and keep going. But I think it has to start by being authentic and being who you are, and that's how you develop your biggest potential. What we're trying to show you is the kind of immense possibilities on the menu.